Hi everyone, this is Lahir from ABC's Anaesthesia, and in this video, I'm going to go through a few niche topics in crisis management, and this is really a follow-up of the crisis management lecture where I go through the whole framework, the 4-phase framework, where we diagnose and treat, just general intraoperative problems. But this one, we're going to go through a few niche things. So we're going to go through laryngospasm, an IV falling out in induction and hypotension, bronchospasm, as well as difficult airway, not in theatre, but on the ward, and the nuances of that. Also, we're going to go through what happens when you have failing metaraminol. So you keep giving metaraminol and the blood pressure just doesn't seem to sort itself out. And finally, failing regional anesthesia and what to do about that. So let's get started. So bonus rounds, immersive crises with tips and tricks. So let's say we've got an 18-year-old male, 80 kilograms for wrist open reduction, internal fixation. So just quickly, what's your choice of anaesthetic for that, Rory?
So I guess you've got a few types. Yeah, I guess if he's got neither comorbidities, neither anaesthetic risk, you could just go for it, and he's well fasted, it's not an emergency. So semi-elective, you could go for a straightforward GA on an LMA if he's
I would do exactly that. What are your doses for that?
18-year-old, 80 kilos, presumably a big drinker. We're in central Queensland. So start with 200 propofol, have a little bit up your sleeve, 100, 150 of fentanyl, maybe some vaseline prior, and then bag him down with some Sevo, make sure he's well relaxed, top him up with propofol if you're struggling.
Beautiful. Let's say that you've done that induction, and let's say for whatever reason you're trying to bag mask the patient, and then the patient suddenly, you feel that they've become tense and you're unable to ventilate them, and the jaw seems just very tight. What do you do then?
Well, I guess this is not an unreasonable situation. We'd probably want to call for help early, since we are not able to ventilate. I'm going to deepen my anaesthetic, so that'll be a combination of volatile and perhaps propofol. Then I guess my first, whoever arrives first, I'll be at the airway. I'll probably direct them to tell them what's happening and then paralyze the patient, and then move to our plan B, which is probably to intubate them. That's probably my first steps. I guess that's in the setting of a strong young patient who's just not deep enough. I guess the things that we're worried about are anaphylaxis and upper airway obstruction that's not simply due to a shallow anaesthetic. So we probably move down the list after we paralyze them and try to secure an airway if we're able to oxygenate and ventilate after that.
What do you give for paralysis?
So in my emergency drugs, I've usually just got 100 of succinylcholine drawn up.
Great.
So we ask for that in the first instance.
Fantastic. So you've gone straight for the solution, which is completely reasonable. So let's say this was it probably doesn't matter if it was laryngospasm or just tightness because of not enough agents for this patient who was on a few benders over the last 18 years or so. And let's say it doesn't matter what it is. You've given relaxant, that actually solves the problem. Now, if I was to ask you, Rory, what is your management steps for laryngospasm, or what would you say they are? Let's say the patient hasn't desaturated yet, but you've got let's say you get an LMA down and you still can't ventilate the patient. They seem still pretty tight. What are your escalation steps?
So call for help and check our monitors, and then temporize. So I go to FI2 of 100. Increase our flow, make sure we're on the bag, assess our compliance or how much obstruction there is on the bag, check our seal on our LMAs, it's the appropriate airway, increase the depth of anesthesia, so turn up volatiles if we've got one running, hopefully Sevo is the best in this instance, and deepen our anesthetic with anything intravenous like propofol or an opioid.
That's actually really good, right? So you've gone through. Again, there's now a specific scenario, so slightly different, where the diagnosis is actually quite obvious. It's some level of tone in the upper area, laryngospasm or upper airway, and you just know that you need to manage it. You call for help. You can, scan your monitors to obviously make sure that everything else is okay. And then look, so I like the fact that you managed it very definitively, and I don't think that doesn't take away anything from what I'm saying now. So I remove the trigger, I apply positive pressure ventilation, which you did. I deepen the anesthetic with propofol, and then ultimately my solution is succinylcholine. The fact that you went to suck straight away, I think, is actually completely reasonable, because you could stuff around with all this other stuff, but ultimately, so many people would stuff around with all the other stuff, and they may or may not get to a solution. But giving this will definitely get you to that solution. And Sux is a very safe drug. It causes anaphylaxis at a rate of 1 in 5,000, but it's still very safe. And you went straight for that. So the insider tip here is, which I didn't get to demonstrate with you because you pretty much went straight to the solution. So if the patient does spasm and you notice the SATs are 60, I'd almost make that same argument that you want to go straight to the final solution here of succinylcholine. So say you've learnt the management of laryngospasm, that only is the management when you have time. And if you don't have time, or maybe you're out somewhere and you don't have too much help, or you don't have too much assistance, and the stuff is hard to manage, I would go straight to the ultimate solution of this succinylcholine, because you just don't have time to waste with all the other stuff. So what do you change? Just straight to Sux. Good. So that's kind of laryngospasm management, and in a progressive escalation framework. But know that you go straight to succinylcholine if things are really bad. Okay, let's go for this next one. 50-year-old obese man desaturates on the ward. You're called to a code blue for desaturation. Let's say the SATs have dropped to 50%. You arrive to see a 150-kilogram bearded man looking very blue. What do you do? Now, I know you guys have had a fantastic Airway talk last week. Yeah, who wants to have a go next? Actually, before we go on, consider small dose of laryngospasm. Yeah, absolutely. So I think Greg mentioned correctly, they talk about like a 20 milligram dose, or like a, was it 0.25 per kilo kind of dose. And yeah, I'm going to say every time this has happened, I've just gone straight for the 100 of Sux, just because I want them paralyzed immediately and for a decent amount of time, because I'm already in a problematic situation. But definitely all you need, like when we do ECTs, you don't need that much succinylcholine for it to work. You'll be surprised that 20, 30, 50 for anyone will still paralyze, definitely paralyze the cords. Sorry, back to you, Greg. Who wants to go?
Fraser's next.
Hey Fraser, what do you do?
Yeah, so my approach for this situation is probably a little bit different, I suppose, because it's not really an anaesthetic. It's not an anesthetized patient. We're not sort of in a controlled environment. So in a bit of an unfamiliar environment on the ward, without necessarily the gear that we're used to. So we're calling for help very, very early in the situation, unless I'm the help, in which case panic. No. So we're making sure that we've got plenty of hands on deck. We have the crash cart in. Depending on where the patient's located, assuming they're in the bed, we want to just try and get some wall oxygen onto the patient immediately as our first priority.
Actually, and let's say you arrive there and one of the nurses at the head of the bed, and they've got a bag mask and the oxygen's connected, but they're not having much luck bag masking the patient.
Okay, no worries. So at this stage, I'm also trying to work out what the patient's other obs are doing. Is this because he's got an airway obstruction, or is it because he's got no cardiac output?
You've got a SATs probe there, and the SATs has a trace, and the SATs says 50%. There's no other obs, but a cycled blood pressure previously, and the blood pressure reads 130 or something like that. But you're on the ward, so there's no other monitors.
Sure. So in this obese fella, I'm starting to get concerned that this is potentially an upper airway obstruction or some sort of obstruction that's causing him to be hypoxic. Whether that's just due to, the combination of factors, particularly his obesity. Is this gentleman on a lot of opioids? Has he inhaled his hospital?
Now, I'm going to stop you there, because the SATs are 50%, and I reckon that you don't care what the diagnosis is.
Sure. So my priority is to ventilate this patient. So essentially, I'm looking to gain an airway. So, which I haven't done at the moment. So first things first, I'd firstly attempt just to try and bag the patient with a Goodell, if possible.
Let's say that fails.
Okay. So that's not working. Have I got IV access?
You do.
Cool. So at this stage with stats like that, he's probably got quite a high CO2 and he's probably peri-arrest.
Mm-hmm.
So I need to gain a definitive airway as rapidly as possible.
Mm-hmm.
And
if you were to tell me a framework that you're going to use, it's always useful in really horrendous multi kind of factor scenarios to outline the guideline or framework that you choose to use, and then the examiner has a shared mental model. They go, okay, Fraser's going to talk about this, this, and this. Great.
Yeah.
What do you reckon?
Yeah, so I guess your two choices are like the DAS guidelines or the Vortex model.
Which one do you want to use?
I like the Vortex.
Fantastic.
We learned about it last week.
Exactly. And so don't even give an option in the situation. Because we're going to use the Vortex approach. Go for it. So tell me about that. You try bag masking and you put a Goodell, doesn't work.
Sure. So haven't optimized anything. Haven't changed anything there. Yep. Thanks. Greg's got the Vortex there. Cool. It's got a really yeah, so essentially I've tried to bag mask this patient with an adjunct, change something, no luck. My choices then are to basically deepen or paralyze the patient. We're on the ward. He's sat to 50, he's peri-arrest. I need to just move on to my next option. Mm-hmm. To be honest, my first instinct here is probably just go straight for a tube, really.
Mm-hmm. Right. Let's say you have a go and you can't see anything in the airway.
Yeah,
it's a grade 4 view.
Okay, so again, I need to change something. So I need to try and get the patient in an adequate position, change my laryngoscope. I don't know what I have handy there.
It's just the ward, so literally you've just got in the cardiac arrest trolley plastic.
Yep, okay, all right. So, well, then I'd proceed straight to an LMA. I'd try the nearest LMA that I've got handy there, probably size 5 for this fellow.
That's good. The stats are now 20%, and the LMA also you can't ventilate.
All right, I'm going to cut the neck.
Okay, tell me about
that. So I'm going to grab the surgical airway kit, which is hopefully right there, and I'm going to take. Is it a size 10 scalpel? 10 blade?
And that's the good thing about scalpels. I wouldn't care what size it is as long as it's a scalpel.
Sure, so go for it. So palpate my anatomy, cricothyroid membrane.
What is this technique you're about to tell me, by the way? Again, flag it before you go into it.
So a cricothyroidomy, is that what you mean?
In the Herd, have you heard of the Herd algorithm or Andrew Herd? They talk about needle cric, scalpel bougie.
Oh, right, sorry, yeah. Oh no, so scalpel bougie is my surgical airway of choice.
Okay, now I just want to tell everyone again, so there's this whole algorithm about needle cric or scalpel bougie or scalpel finger, and there's a whole algorithm for this. I'm going to tell you that it doesn't really matter which one you use, but in theatre. But trust me that if you're trying to do something on the ward and they don't have all the equipment like jet ventilators and 14 gauges and all that, it's so much easier to describe a scalpel bougie and also to source the equipment, because what piece of equipment do you need, Fraser, for a scalpel bougie technique?
Scalpel bougie, size 6 tube.
Exactly. And if you ever try to describe a needle cric technique, it literally sounds horrendous. If you're trying to explain it, so on the ward, also trying to explain it to someone else to do, scalpel bougie by far is what you do. So that's great, Fraser. So again, you've called for help, you've scanned the environment as you normally would do, and you've checked the reading, obviously, because the patient's, got a stats of 50%. Temporarization, diagnosis, and treatment, it's already really occurring, and that's why you know what the problem is, that the respiratory arrest, and you need to tackle this. I highlight the fact that I'm going to do the Vortex approach or the DAS approach, but just pick one and choose it. And then I systematically, what you did there, optimize each one as best as you can. And I've got a whole spiel for this. So I will systematically go through bag masking, LMA, and endotracheal intubation, and then get someone ready with a scalpel bougie in case I fail, because the stats are already 50%. So I outlined 2 teams, and that's just kind of part of the strategy of crisis management. I bag mask with 2 hands and an assistant, Goodell, jaw thrust, and other airway maneuvers. If that fails, I try an LMA size 5, the one with the best seal. If there's an iGel there, I'd try that, and then optimize that. And if I could possibly call for video laryngoscope, I then do my attempt at the tube while my colleague is prepping for a scalpel bougie technique for the neck. And for optimization, I would use burp, bougie, new blade, whatever I need. Yeah, that was really well done.
Hey, Lahiro, matching colors, look. Vortex and...
what's the other one?
Well, it's a practice larynx.
Vortex branded, nice one.
Yeah, there you go.
That's great.
So Josephine's next.
Beautiful. So again, just what we mentioned, outside of theatre, surgical airways are even more difficult. Easiest one to access, describe, and do is a scalpel bougie size 6 tube technique. Imagine trying to explain and find the equipment for a needle crike with jet ventilation. Okay, 30-year-old smoker for lap appendicectomy. What's your induction? Sorry, was it Josephine?
Yep.
Yeah, what's your induction, Josephine? Assume whatever you want to assume. Let's say they're 70 kilos.
So I would give probably 2 milligrams of Midaz, 100 of fentanyl, and 150 of propofol, but happy to go up to 200 if they're a drinker or there's some drug use. And then I would intubate them with a...
relaxant, which one are you using?
Sorry, relaxant. I would use Beck, really for no particular reason. That's just the one I'm most familiar with.
So you wouldn't do a rapid sequence in the lap appendicectomy?
Sorry.
No, that's fine.
Yes. If they've been in hospital for 3 days and fasted, and this is something that is semi-elective, I would think about whether it definitely needed to be done. But if they were vomiting, septic, acutely unwell, then I would. Yeah.
And Josephine, I actually completely agree with you. I think a well-ish, not vomiting lap appendix is in the lowest risk of aspiration in that kind of spectrum of aspiration risk. And let's say an exam, just say rapid sequence, because that would be the safest thing to say. But I completely agree with you. So you do the induction. ET goes in. After you put the ETT in, what's your very next step? So you've literally put the ETT in. Nurse holds the tube, or the assistant holds the tube. What's your very next step then?
So is this after I've confirmed that it's in the right spot by looking at the misting and the CO2 and the chest rise and fall?
You've literally put it in and said, please hold the tube. What do you do next?
So then I connect to the circuit and then bag.
And what do you dial on the APL valve?
At about like 15 to 20.
Right. You dial to 15 or 20. Let's say you dial to 15 and it just collapses.
Okay. So I'd check that my flows were turned up to...
There's 6 liters or whatever you started with.
Yeah. Okay. And then it collapses. So my first concern is that, I'd confirm that again. Probably call for help at that stage if it was... I call for help because this airway is not going the way that I expected. And then I would scan the monitor to make sure, see what my O2 sats were, which is probably the thing that I'm most concerned about.
Which is still good, yeah.
Yeah. And then my temporizing measure, if I, temporizing measure, I'd first just check the connections. So make sure that I was still connected to all the rest of the tubing and that there was no kinking there.
There is none, and there's no disconnections.
Okay. And then I would, if the sats are still appropriate, so above 95, I'd ask for the Liddell bag and see that if I could bag using that, so separating from the machine. And then
let's say you don't have a Liddell bag. Actually, what do you think? Okay, so you do put the Liddell bag on, and it actually feels like a rock. What's going on? Like it's... So
I assume that I have done a esophageal intubation. So I have the patient's not intubated. That's my number one concern.
Actually, that's really good. So that's a really good thing to talk about. So Josephine had the valve on 15 and the bag collapsed. You then connected the Liddell bag, and then you were unable to compress it. It felt really hard. So the bagging circuit is loose or collapses, but your airway, your Liddell bag, I didn't want to go into the Liddell bag situation because there's a lot of variances with the Liddell bag that I can't describe right now. But anyway, what do you think is going on, and why is there such a big difference there? Okay,
I'm not really sure.
No, that's completely fine. How about the Liddell bag is, you've got that on now and you just can't seem to ventilate. It feels like a rock. What do you think is going on?
So the two scenarios that I'm most worried about are, one, there's like a bronchospasm maybe related to an anaphylaxis, or that
that's
the
exactly
in the wrong spot.
That's exactly what's going on. So now the subtlety here is you turned your APL valve to 15, right? And I encourage everyone to try this. You can only differentiate bronchospasm from a misplaced tube if you increase your pressure. So you did exactly the right thing, which is turn the APL to 15 or 20. But if it's the worst bronchospasm that you'll experience, it will literally get to that pressure as soon as you clench your fingers even a little bit, and then it will release the pressure because the APL valve is too low. And so the very next step that I'd do is turn it to 70 to confirm what my problem is. Because once it's turned to 70, you'll realize that, oh, it's now a tight problem, not a displacement of air problem. That way, you know straight away that it's either, so if it's in the lungs, you always have, you never have a loss of air. Whereas if it's outside the lungs or in the esophagus, you will always get that collapsing thing no matter what the pressure is. But APL to 70 is the next step, and gradual inflation of that. So that was just a little subtlety, but you've got bronchospasm, right? Mm-hmm. You auscultate the lungs, you confirm the bronchospasm. How do you treat this?
So do they have, I'd be looking to see if they've got any other features of anaphylaxis, so tachycardia and hypotension, mm-hmm. versus just an isolated bronchospasm in the setting of being a smoker with reactive airways.
You recycle the blood pressure and it's just high blood pressure, hypertension, and no hypotension at all. The patient is tachycardic, however, and the SATs are about 90% now.
Okay, so I will double check that my FiO2 is at 100%, which it should be if I've just intubated and the flows are at 10 litres. And am I getting CO2 to confirm that the tube's in the right spot?
Well, because it's severe bronchospasm, there's no other place except with a kink that you'll get such tightness. So even if you're not getting much CO2, you can check, you can reinsert it, but you're probably in the lungs. Let's say you get a blip of CO2 with increased pressures. Okay.
So isolated bronchospasm, my first step would be to give some salbutamol through the tube in line. So I do 12 of the MDIs, yep. And see if that had any effect. And then I'd also, if the blood pressure tolerated it, turn the SIBO up a little bit to get a bit of bronchodilation with Fantastic. That. And then I'd kind of reassess and see where we're at.
Beautiful. And now a quick strategy for the exam is literally to say everything you do. So I would stepwise increase my management from repeated dose of Ventolin, reassessing, increased volatile. What are your other managements for severe bronchospasm that you could talk about? Just give me just list them if you.
So you could also give some atropine, not atropine, I always say atropine, some.
Atrovent, you're thinking.
Atrovent. And then a small dose of adrenaline.
How much?
Also, that's something I always have to look up because I don't.
Right. I'd probably give 10 to 20 mics IV for that scenario because it's going to cause a massive blood pressure issue as well. And what are the other escalation steps?
And then you could also give some IV salbutamol, mm-hmm. and possibly some magnesium as well.
Fantastic. Yes, that's literally the British Thoracic Society talks about this escalation step, and they also mentions magnesium. So what I'm familiar with giving is about 4 grams over 15 minutes, and hopefully that resolves things. But that's great. You can easily talk about the whole progress of your management with in a few quick steps, increasing doses of Ventolin, even IV, maybe even 20 mics, increased volatile, Atrovent, as well as magnesium. And there's suggestion of ketamine as well there. Again, something to talk about, but that's really good. Let's say you start ventilating and your, what are your priorities of ventilation with a severe bronchospasm?
So the main priority is ensuring that they've got adequate expiratory time so that they don't get breath stacking and then at risk of a pneumothorax. Yep,
that's pretty good. Okay, let's say, practically speaking, how do you set your ventilator now? Let's say your SATs are 80% and really severe bronchospasm, you've maximized medical treatment, and now you're setting your ventilator to get your hands free. literally, what do you set your FI to? Actually, I'll go through. What do you set your FiO2 at?
So I'd keep it at 100% until the sats are above 95.
Perfect. Yeah, it's 100%. What do you put your, is it pressure control or volume control that you use?
I would want probably volume control, because
I'm going to say pressure, because pressure is your limiting variable.
yeah.
And if you get the maximum volume for pressure time unit if you use pressure control. So very good. And what pressure would you dial it up to?
As in the max pressure, or?
Yeah, like what do you set your ventilator pressure to deliver to the lungs?
So I would probably start at 10.
So you start at 10, but it's so severe, the bronchospasm, that you get 5 mils tidal volume. What do you do?
I just keep dialing it up until I got to a tidal volume that I was happy with.
Beautiful. You dial up to 40, and you seem to get a tidal volume about 100 mils, and it's maintaining your sats at 80%. It's pretty bad.
Yeah.
What do you dial your rest rate to? This is an actual thing that happened to me in my crit care year. So let's keep going.
Rest rate, like I'd maybe start at 8 and see how it goes, because I don't want them to be too tachypneic, because that will decrease the expiratory time.
That's a fantastic point, right? So like you said, so let's say you go to 8, and then you're right now, oxygenation is terrible, but it's as best as you can make it. Your CO2 is now 70 at a respiratory rate of 8. And then you see your blood pressure dropping. What do you think is going on?
They're probably becoming hypotensive because of their hypocarbia.
Yep. Or the other thing you mentioned, if you have really high
intrathoracic pressure.
Exactly. So you're going towards gas trapping, which can lead to a cardiac arrest. What do you do to treat gas trapping as your breath stacks occur?
So you can just disconnect them from the circuit.
Beautiful. You do so, and then your blood pressure resolves. You reconnect the circuit. What do you dial your rest rate to?
So I probably go lower, so to maybe 5.
Okay, you do it at 5, and your CO2 over the next 5-10 minutes climbs to, it's probably not realistic, it climbs at 4 millimeters mercury per minute, but let's say it gets to 120. What do you do?
Has that person that I called for help arrived? Yeah,
yeah, that's right.
So their CO2 is going up. I can't really increase the rest rate because that's causing breath stacking.
Beautiful.
So I could increase the increase the expiratory time on the ventilator.
You actually said the right thing there. You can't increase the rest rate because you're worried about gas trapping, which is bad. And so the CO2 climbs, and it's got a term. If you just deal with the CO2 and just leave it as it is, what do you call that?
So yeah, permissive hypocarbia. You just accept it as it is. Okay. You
win the situation. So your priorities are oxygenation, permissive hypercapnia, avoiding gas trapping, avoiding barotrauma. And so when I run this kind of situation, you just can't have everything. So you just go, oh, well, CO2 is climbing, patient's healthy. We know from lots and lots of case series that high CO2s temporarily in these young patients are actually fine. I've had a couple of times in lung transplant cases where the CO2 is over 200. It's a temporary thing. We get them on ECMO and sort it out, or the severe asthmatics go to ICU, they recover, and then they blow off their CO2. But it's so much worse to dealing with a cardiac arrest versus a high CO2. So the insider tips for this: pressure control ventilation, maximize volume per time unit pressure. So that's your limiting variable. So that's what I would dial. Because if you notice your monitors, if you use volume control, you get a spike of pressure and then it decreases down. So you're not giving us the maximum pressure for as long a period as possible to get that volume in. Keep less than 40 centimeters, but even if you have to go higher, that 40 centimeters is not received by the alveoli, it's dispersed by the severe bronchospasm. So you may go higher than 40. And there's a thing called plateau pressures. That's what the alveolus is probably seeing. Look it up, as you can measure the plateau pressure as well. Now, everyone talks about IU ratios, and that's really good to talk about with thinking about expiratory time. But just remember, an IU ratio of, let's say we increase from 1 to 2 to 1 to 4. An IU ratio of 1 to 4 at a rest rate of 15 is probably worse than an IU ratio of 1 to 1 with a rest rate of 4. So it's not the the IU ratio that counts. It's the total time in expiration, which you actually mentioned. You said, I want a long time in expiration because that's what counts for these. And it's I focus less on the IU ratios, but make sure my absolute expiratory time is really important. And yeah, if the CO2 climbs, trying to aggressively fix it could cause gas trapping. CO2 is well tolerated in these patients. Cardiac arrest definitely isn't. And there's such a common, and I had this very early on in my career, and it probably happens once a year where I get a severe bronchospasm in a patient. But knowing these priorities will prepare you hopefully for the most severe situation to know what to chase and what not to. Any questions about that before we move on? That's obviously a bit of a mouthful of a scenario.
Yeah, I want to correct something I typed. I said that permissive hypercarbia is all right. It's the hypoxia that kills them. But of course, I'm forgetting it's actually a cardiovascular death, isn't it? It's the gas trapping that's more dangerous even than the hypoxia that you don't always see.
Oh, look, I don't even know where the mortality in this lies. Like it may be barotrauma, maybe. I haven't seen the studies on whether it's hypoxemic deaths or cardiac or gas trapping deaths. But yeah, maybe, I'm not sure.
Sure. But blowing a pneumothorax, I mean, that's
yeah, definitely bad.
not good.
Okay, next one, 60-year-old ex-IVD with fractured ankle for open reduction, internal fixation under GA. The patient is in a lot of pain, so you decide to induce on the bed before transferring onto the table. Now, I don't know if any of you have done this, but you've done the induction, you secure the ECT and you transfer, and then the IV gets caught because it's looped very nicely and catches on something and it pulls out. The next BP reading is 70. What do you do? Who was next?
This is Daniel Brownstein.
Go for it, Daniel. What do you reckon?
Yep. So BP reading is 70. We've got next to IV drug user, potential difficult IV drug, difficult access. But going through my algorithm here, so checking that blood pressure again, having a look at the rest of my monitors, consider sending for help here. We've got a potential difficult IV access and hypotensive patient. Scanning the patient, seeing how they look clinically, and then we'll get them across onto the bed. Surgery hasn't started yet.
Yep.
Temporarization, something I'd be concerned about here is we've got a paralyzed patient with the tube, so I'll be worried about some risk of awareness if they lighten up. So I'll be putting them onto sevofluorine.
Yeah, exactly. So you got them onto sevo, absolutely. So keep going. Sorry.
Yeah, got them onto sevo to maintain their anaesthetic. What we really need here is IV access.
And what are you trying to temporize, by the way? What's the thing you're temporizing?
So I need to temporize the blood pressure.
Perfect.
Is the concern here, and without IV access, that can be quite difficult. So we need to get that pretty quickly.
Let's say your help arrives and they're just looking at this person going, there is nothing here. And I had this patient just yesterday, absolutely nothing. Oh no, actually it was today. Wow, every day is just molding into one. So what do you do? What could you do, knowing that you've got no IV access? What could you do to temporize a situation?
So you could put on as minimal sevoflurane as possible, so reduce that dose, but enough to keep them asleep. Put their legs up as well.
Fantastic. Anything else? Anything you can give that doesn't require IV access to improve the blood pressure? Let's say the blood pressure falls to 40 because of whatever.
I give adrenaline subcut, or IM adrenaline.
Beautiful. And again, always got to give a dose. So now you've probably never thought of this scenario or a dose of adrenaline in this scenario.
Yep.
Well, how do you possibly come up with a dose that's going to be reasonable?
I'd probably just give, if there's that hypotensive, I'd consider something like 0.5 milligrams IM.
Yeah, and that's not crazy. That's pretty hypotensive. So 0.5 milligrams is pretty fair. Like I think in anaphylaxis, the blood pressure could be that, and the guidelines are 0.5. So anywhere from kind of 0.2 to 0.5, I think is reasonable. Another drug. What is there any other inotropic drugs that is in your drawer that you could give IM?
Ephedrine.
Yeah, the formulation we have, we can give. I know they brought out a new formulation that isn't for IM, but the one I've got is, so I absolutely have given that 30 milligrams straight up into the deltoid muscle for this situation. Okay, great. So we've got our temporization stuff, and that's going to buy you a lot of time. Tell me about how you're going to get this IV. Tell me the kind of all the different things you could have people working on.
So have people looking at multiple different limbs at the same time.
Perfect.
Ultrasound being brought into the room to assess for IV access that way. And if worse comes to worse, if it's an absolute emergency, we'd be considering something like an IO access or a central line.
Done. That's actually all there. So, call for help. There's not much in this about scanning, but because it's just a one-dimensional problem. Temporizes legs up, intramuscular agents, which we mentioned, and the doses, then diagnose and treat. So really, that's your problem here is literally a diagnosis lack of IV access with a hypotensive patient. So help, ultrasound, intraosseous CVC, legs, wrists. There is a vein somewhere. Like the number of times I've gone on the back of the wrist for these kind of situations, or not these situations, but these IV drug use patients is all the time. Okay, let's say you're called to help. Only a couple more cases, guys, so thanks for sticking with us. 70-year-old female bowel resection, past history, ischemic heart disease, stent 5 years ago, ejection fraction 40% on a recent echo, and the blood pressure is 70 despite a repeated metaraminol. What do you do?
Vivian now.
Go for it.
Oh, okay. So they're in theatre on the table or something? Is that
let's say they're kind of into a bowel resection, let's say 30 minutes into the dissection. It's an open dissection. And yeah, let's say you've been giving aramine for a while and it's just increasing requirements, and now the blood pressure is still 70 even after repeated doses.
Okay. I mean, well, you need to temporize, make sure you've got fluid going in. You could try some ephedrine. You can see what could be going on in the middle of bowel section. Are they losing a lot of blood? They might need blood if it's from a bleed.
That's so good. And
if it's some drugs you give them, maybe they're having a anaphylaxis and you need adrenaline instead of metaraminol.
You've actually got to the solution straight away, Vivian. So I'm not going to bother you with, we've done hypertensive scenarios and the frameworks and everything, but essentially the systematic check is, preload, rate, rhythm, afterload, and contractility. And so you can rule out each pretty easily. What are the surgeons doing? What's the volume status? You can even look at pulse pressure variation on the outline. I know the rate on the monitor. I know the rhythm. And I've given aramine. So the afterload and preload have kind of been treated with fluids and aramine. But the contractility is a thing that can really be a thing that people forget to address. So failing metaraminol happens, all the time, really. Metaraminol is alpha. It addresses preload and afterload, but doesn't really affect beta. So in this patient with CCF and ejection fraction that's low, plus you're giving drugs like propofol and volatiles that are, negative inotropes, you just sometimes need to give ephedrine. You give that straight away, which is really good. It's part of your temporization. So yeah, that's just one of those, again, practice points. You'll have the aramine drawn up. That's the first thing you're giving. But in certain situations, you got to stop giving it and think, is this a contractility issue? It's not the same patterns before. Likewise with that pneumoperitoneum bradycardia case, just watch out for the reflex bradycardias as well. Excellent. I think this is our last case, really. Who loves regional anesthesia? Do you guys do much regional? Put your hands up if you do. No, all good. Okay, let's say you've got a 30-year-old G1 P0 for elective cesarean. What dose spinal do you use? Has anyone done too many of these in your training?
We'll go for a volunteer here.
Yeah, go for it.
I'll go like 2 point. Oh,
there you go, Vivian.
Sorry. Oh, I don't want to take someone else's go, but 2.2 mils of 0.5 bupivacaine. I'll go heavy, and I'll go 15 mics of fentanyl. And
that's exactly what most of us use at our hospital as well, and sometimes we use intrathecal morphine as well. Let's say the baby is delivered, the patient complains of sharp pain. Yeah, who wants to have a go at this? What do you do from here?
Yeah, hi, Larue. I'll have a go.
Yeah, go for it, Calvin.
So essentially, in a sort of a stepwise fashion, I'd start with reassurance with the patient and confirm where the pain is, and just sort of characterise what the complaint is, just to confirm it's
it's super sharp.
Nociceptive pain as opposed to some other sort of pain.
Yeah, super sharp as soon as they're doing the stitching of their let's say the muscular layers.
So I'd be reaching for the other 85 mic of fentanyl I have on the shelf, and probably give 50 mic to start with. and see if that temporizes the situation.
It doesn't help much at all. The surgeons are still going away and it's hurting her a lot.
Yep. So then an escalation, I think the agents I'd be wanting to use in situations a small amount of ketamine, either 10 and 20 milligram sort of bolus, and maybe some tramadol. But I would be quickly reassuring the patient that if these interim measures didn't address her situation, that we may have to convert to a general anaesthetic.
Yeah. Okay. Good. And that was pretty comprehensive. You got there very quickly to offering the GA, which is definitely good. One of the things that we talk about in there was a case, potentially it was decades ago, but there was a massive lawsuit where a patient did feel pain and they weren't offered a GA. So it's one of those things that you have to do very quickly. Anyway, the framework, again, you might need a call for help. Because again, if you're junior, this is a very complicated thing to manage, and you may need to go for a GA, and GACs are inevitably quite difficult. The first thing I would definitely do is ask them to stop the surgery, because you just don't want a patient in pain while the surgeon's still stitching, and it's a very easy thing for them to do to stop the surgery. I'd assess the pain exactly what you said. I'd offer a GA at the very start, and then how much I progress with my plan of temporizing and trying to give analgesia depends on where they're at with the surgery. So just remember that if this is pre-baby delivered, you really don't have too many options. Like if they're already about to get into the uterus, you won't be able to temporize with enough analgesics. So you'll probably have to go to GA. But if it's onto the skin layers, there's a lot of things you can do. So just note the time of the surgery as well. So stop the surgery, assess pain, offer GA, and then analgesia. And there's so many different, we're talking about the analgesia ladder, but in anesthesia, we just got to do it very quickly. So here's the analgesia rocket. We've got a lot of stuff already for, we've got alfentanil on hand. So I'd give the 85 mic straight up and maybe get alfentanil, even remifentanil, because it's so effective. Midazolam, because hopefully they don't remember anything. In pain, I definitely don't want them to remember too much. And then I can use a lot of things like nitrous or even penthrane if that's easily accessible from pharmacy, the green whistle. And then local in the wound is the other thing that's really useful. And they've got, you've got so much ability to do that very quickly. And finally, things like ketamine. And that's my, for any, so this is I just copy paste this for any regional anesthesia scenario where essentially it's not working well enough. I just go, fentanyl, midaz, nitrous, penthrane, local in wound, ketamine, and then progress onto the general anesthetic at the very end of that. Any questions about any of those specific scenarios?
I do have a quick question. I want to pick your brain about this.
Yeah, sure.
I have never seen narcotic induced chest wall rigidity. I know that remifentanil could cause that.
Yeah.
If on my own, listen, because I had a patient today who I was working on my own today, and I induced the patient, and the pressures went quickly up. I knew she was a smoker, weed smoker, cigarette smoker. So initially thought it was the lungs, but I was on my own. I had quickly, I was looking how to differentiate between chest wall rigidity and bronchospasm before I listened to the chest. Is there any early signs that you can see will give you sent to either way?
Yeah, absolutely. So chest wall rigidity, the times it's happened in my practice is when I've given bolus doses of remifentanil. So, if you ever want to treat chest wall rigidity or severe bradycardias, give 100 mics of, give up to 100 mics of remifentanil, and you'll probably see it every now and again. So first of all, chest wall rigidity in opioids, definitely when I was studying it, it just wasn't a very well-known thing. Like, it's something that occasionally happened, but we weren't really sure why it happened. And, there's all these theories about why it could happen, but essentially I would manage it like I'd manage any other obstructive type problem and an airway problem. So essentially use my temporizing things, oxygen, bag masking the patient. If I can't bag mask, I've got an obstruction of some sort, deepen, paralysis, and auscultate the lungs, because that will give me a diagnosis of bronchospasm straight away. Without the bronchospasm sounds on auscultation, then I'm worried about chest wall rigidity if it's an opioid, but also knowing that if it is that, it resolves pretty quickly. So chest wall rigidity is the one thing I'm kind of worried about, but I know that if it is that, it just resolves reasonably quickly, and I don't have a problem 10 seconds, 20 seconds later. Hope that answers your question, Kenny. Yeah, so look, I thought I'd run the frameworks for generic stuff, generic things occurring, SATs decreasing, hypertension, etc. Because I think it's very useful for almost every scenario you'll get. But then there's certain scenarios like these ones that are just stuff that a lot of anaesthetists talk about because it happens in practice, and it's some of the stuff that we just have examined each other on over years and decades. So laryngospasm, difficult airway on the ward is very different to in the theatre. Bronchospasm, IV falls out, what do you do? Hypotension in the cardiac patient, again, giving ephedrine, not just aramine the whole time, and then failed regional anesthesia. Just a spattering of a few interesting things that may come up in your exams because, yeah, that's what we talk about. Thanks very much for listening, guys. So obviously we don't have time for the full-on crisis management scenario stuff, but yeah, maybe for another time.
There's lots of appreciation coming through and love in the chat room. So, and a couple had to leave already, and they said so. Marathon effort tonight. It's a long day, but yeah, that was terrific, and I appreciate it.
Thanks very much for having me on, Greg. Really love coming here to chat to you guys.